Webinar on culture change. So before we get going, I would like to acknowledge the traditional custodians on the various lands on which we work today and meet today. I pay my respects to elders, past, present and emerging. In terms of our webinar series, the aim of this webinar series is to bring together addiction researchers, clinicians and other experts from the sector to discuss emerging research and challenges within the addiction field. Today's topic is culture change with a focus on alcohol. To date, most efforts to address alcohol-related harm have really focused on targeting individuals, and considering the social context that surrounds alcohol use has gained more recent recognition as a key important thing to consider if we are going to address population-level harms of alcohol. So this makes it really critical for us to understand what broader strategies might be important in understanding culture change and how to effectively drive these changes. So we have two excellent speakers and a discussant who are going to talk on this topic today. So without any further delay, I would like to introduce those speakers. First, we have Dr. Michael Savic, who's the Strategic Lead of Clinical and Social Research at Turning Point. Michael's research focuses on the social and cultural contexts of alcohol and other drug use, addiction concepts, treatment experiences, and implementation across several mediums. His research is multidisciplinary in orientation, policy and practice relevant, and often draws on clinical approaches and qualitative methods. Our second speaker today is going to be Dr. Liz Sturgiss, who's a GP and a Senior Research Fellow at the Department of General Practice. Liz is a practicing GP, so in addition to her academic role, a practicing GP who cares for people with substance dependence and complex multimorbidity. Liz leads an emerging research program on the management of complex and stigmatised health issues in primary care, focusing on translating guidelines into real-world practice. Her research is based on theoretical principles from behaviour change and implementation science. As a clinical researcher, she has extensive networks with clinical primary care colleagues and in her representative roles with primary care organisations. And our discussant today is going to be Dr. Tina Lamb, who I work with at the Monash Addiction Research Centre. Dr. Lamb is a research fellow at the Monash Addiction Research Centre with research interests in alcohol and opioid-related harms. She's been influential in leading alcohol policy work, including work with a focus on young people. She's informed the National Alcohol Strategy and informed the National Drug Strategy Household Survey methods. And Dr. Lamb has led national studies on young people and their alcohol use, treatment pathways and alcohol and other drug use within nighttime entertainment districts. Before I hand over to Dr. Savic, I'd just like to remind people that we absolutely welcome questions today, and we're hoping for a fantastic discussion. If you could put those questions into the Q&A chat so that we can see them, feel free to do that as you go. There's no need to wait till the end. So without further ado, I'll hand over to Dr. Savic.
Thanks, Susie. Thanks for that warm welcome. Just share my screen. Thanks for having me here today. It's a real privilege and pleasure to be presenting as part of this webinar. I'd also like to acknowledge the Wurundjeri people as the traditional owners of the unceded land I'm streaming from and from which the projects I'm going to be talking about relate to. And I also pay my respects to elders past, present and future at this meeting and beyond. So I guess this talk is about the potential of stories and art in culture change, and I'd like to acknowledge the long histories and wealth of expertise of Aboriginal and Torres Strait Islander people in terms of story and art. So today I'll present some findings from the What's Your Story project, which I was involved in evaluating with Emma Sandrell and James Wilson. This was a project funded through Vic Health's Alcohol Culture Change Initiative to change the drinking cultures and norms of young adults through the use of stories and public art. And I'll particularly focus on the public art component today. But before we get into that, I'll reflect briefly on drinking cultures and how a drinking cultures perspective might differ from conventional public health approaches. I guess the first thing to say about drinking cultures is that policymakers and academics and also the alcohol industry are increasingly interested in them. And also in changing them, particularly sort of academics and policymakers, without really defining what drinking cultures are. So given that kind of conceptual ambiguity, we pulled together bits and pieces of literature on drinking cultures and proposed the working definition you can see on the screen. As you can see by the length of the definition, understanding drinking cultures is not so simple or straightforward, and we're trying to wrangle with some of that complexity. But thankfully, Vic Health came along and proposed a shorter definition in their alcohol cultures framework, which some of you might be familiar with. They say that drinking cultures are about the way a group of people drink, including their shared understandings of formal rules, social norms, practices, values, and beliefs around what is and what is not socially acceptable when they get together. I suppose a drinking cultures perspective invites a few shifts in thinking from conventional public health approaches. Firstly, it potentially shifts the focus from individual behaviour to a focus on the norms or the rules and expectations around drinking that operate in subgroups in a society. So, for example, young adults. The second is that while we often hear people talking about Australia's drinking culture, a drinking culture perspective would draw attention to the multiplicity of drinking cultures that might operate within any society. While acknowledging the importance of traditional public health approaches that often focus either on things like alcohol availability and price at the societal level or on individual behaviour change at the other end of the spectrum, a drinking culture perspective invites a focus on the settings, skills and shared meanings that materialise in social worlds. Similarly, it's important to bear in mind that drinking cultures don't simply cause drinking practices, pleasures or harms. Instead, I think Sarah McLean and David Moore articulate this well when they say the discomforts as well as pleasures that people experience within the inner city emerge from specific assemblages of alcohol, embodiment, affect and place, rather than from one discrete body they're in. So not just the alcohol or the young adult, it's about them coming together. So in other words, we need to shift our focus towards the bundle of interacting elements at play in any given situation, rather than isolating and narrowing in on one element alone. Finally, I think a drinking cultures perspective potentially invites or benefits from a view of culture on the move, however slowly that may be. Unlike the view that culture is simply transmitted onto people through cultural transporters, Hannah's here talks about culture in terms of networks of meaning that are continuously being renegotiated and reconstituted rather than just being transmitted. I think this is a fruitful way of looking at culture because it means that if norms and practices are always being renegotiated and reconstituted, then there's an opportunity for them to be constituted in new or different ways. And I think while norms and practices among subpopulations and social worlds are unlikely to change overnight, I think through repeatedly and through repetition and repeatedly reconstituting them in particular different ways, these changed norms and practices may take hold and endure. And I think we only need to look at things like smoking for a good example of that. This then kind of brings me to the question of how to facilitate alcohol culture change. There is, of course, a question before this one about why and what needs to change. And embedded in that question are all sorts of assumptions about what the problem is or what the problem ought to be. You know, is alcohol the problem? Is it masculinity? Is it the alcohol industry? Or is it a whole lot of things all bundled up together? But I think that might be a presentation for another time. So I'm going to, in addressing that question about tools for alcohol culture change, I'll turn to some insights from the What's Your Story Alcohol Culture Change Initiative. So basically this project involved collecting stories through the pop-up story pod that you can see there on the screen, and then analysing and then sharing young adult stories of going out to highlight the diversity of experiences on a night out, and also to foreground some of the changes in norms and practices around alcohol that we're already seeing in the community in order to encourage further shifts in norms around alcohol. So as well as sharing stories online and via social media, the project also shared these through three-month-long public art installations in nighttime entertainment precincts in Melbourne. So people were not only engaging with the stories and norms, but also engaging with nighttime entertainment precincts in new ways. Basically, each installation, which were developed by John Fish Studios, and which you can see there on the screen, drew inspiration from music festival design and key themes and quotes from stories, as you can see on the other side of the screen. These included around highlighting other elements that play on a good night out, and including things like music and social connection, and around savouring and remembering nights out. I should also mention that we gained obviously people's informed consent and approval to use their images as part of the campaign and as well as the research. But why use young adult stories and art as tools to facilitate culture change? Where did that idea come from? Well, it's certainly not a new idea or one that we came up with. Stories are a great way of disrupting, amplifying, and changing cultural norms and practices. And we only need to look at a range of stigma reduction initiatives that draw on lived experience stories to humanize people, normalize their experiences, and offer different ways of understanding these. And there's a small selection that you can see there on the screen, but there are also many other great ones out there too. While we know a bit about stories and why they might be useful in facilitating culture change, as the speech bubbles that you can see there on the screen suggest, I think we know less about how people might engage with public art in the service of alcohol culture change. And so I'm going to focus on our evaluation findings related to that. So we examined this issue through qualitative analysis of researcher observations and on-site interviews with 55 people who engaged with the installations. As you can see here from our clipboards and name tags, that's myself and Emma there, we really didn't blend into the environment as good ethnographers should. In fact, we blended in or didn't blend in so well that lots of people asked about what product or self-improvement program we were selling. And I guess I don't know about self-improvement, but today I'll talk about 3 interconnected elements influencing engagement with installations, namely the design of the installations, the messaging, and dynamic spaces and atmospheres. And I'll reflect on the effects that flowed from these. So firstly, the design of the public art installations influenced how appealing they were to engage in and the ways in which people interacted with them. Installations that had interesting and playful visual design elements that afforded a range of possibilities for interaction were particularly well received. Here, Tom comments on the neon lights and the attractiveness of one of the installations, which he said would be great to post on Instagram. Indeed, we observed groups of friends and partners taking photos while interacting with the installations, and many of these were shared on social media, including the photo on the screen, from which flowed a range of other interactions and effects in terms of engaging with culture change and the messages of culture change that the project was conveying. Some participants also asked strangers to take a photo of them interacting with the installation. So this sometimes evolved into conversations, which also underscores the way in which visually appealing installations afforded possibilities for loose social connection and kind of enhanced people's nights out. As well as posing for photos, some installation afforded possibilities for play, fun, dance, and promoting other practices or products, as is the case on the photo on the right. So this is from a video posted on Instagram from a Zumba instructor who danced in front of one of the installations that we observed, with hashtags like hashtag Zumba love and hashtag Zumba class, which I suppose underscores the potential of installations to become different things to what was intended when they intersect with other elements in unpredictable implementation situations. So in this case, the installations became a tool for marketing a class, and it certainly wasn't our or the project's intention to do that. Secondly, the messages conveyed by the installations were important, not only in encouraging engagement with the installations, but also in terms of stimulating reflection on drinking cultures and drinking practices, which was the main culture change impact we noted from the project. Overall, the 2 subtle and positively framed messages, "Savor it or remember it," and "Music is all I need," that didn't single out alcohol, resonated most and stimulated most reflection, even though some people didn't immediately understand the message or its relationship to alcohol. So commenting on "Savor it, remember it," John says, It's a great message, but it's too subtle. But it's not necessarily as confrontational as the message that you're trying to get across, right? Because when you're telling people that they're doing something wrong, nobody wants to hear that they're being an asshole. As Faye suggests, one of the key effects, Faye at the top there, one of the key effects of engagement with the subtler messages was that they sparked thoughts and reflections about cultures, practices, and meanings, as you can see there on the screen. As Mario and Ravi suggest down the bottom there, across all three installations, many agreed that drinking is not the only element on a good night out. It's the moment, people, and places, as Ravi says, as well as the music and dancing, according to Mario. However, most participants also acknowledged the pleasures of alcohol use and were skeptical of the explicit and negatively framed alcohol-related message, drinking isn't center stage, which they perceived as displacing drinking from the night altogether. For example, Dan said, I fully support drinking. I think life is better when you drink. It takes away the pain, makes you feel a little better, takes away your inhibitions. To be honest with you, drinking isn't center stage, doesn't resonate with me at all. This, I think, reiterates the value of carefully engaging with alcohol-related pleasure in culture change projects rather than ignoring it altogether. Finally, the public spaces and dynamic contexts in which art installations were situated were influential and sometimes resulted in unanticipated forms of engagement. So the Music Is All I Need installation, for example, was central to was situated in a busy thoroughfare and flanked by several venues and a bottle shop, which you can see there on the screen. So right in the thick of the alcohol cultures it was attempting to unsettle. The atmosphere, I guess, initially felt fun with a much higher kind of energy and engagement compared to other installations and with lots of people surrounding the location. But we noted that towards the end of the evening, a large crowd of over 100 people gathered around the installation, and you can kind of see some of that there. They were attracted by a performance taking place in front of what was part of a Latin music festival. So it incidentally reinforced the message of music is all I need on the installation. And this was sort of unscripted and not part of the programming in terms of the installation. But almost, so in some ways it was a bit of a win for the project in that the message was being reinforced. But almost immediately after the performance finished, the crowd dispersed and a rowdy group of middle-aged men approached the installation and took photos of the performers, who were largely women. So with this sort of uneasy shift in the atmosphere ushered in by the men and the objectifying male gaze, the installation was subtly enrolled into troubling masculine norms, the sorts of masculine norms that other alcohol culture change efforts are seeking to address or could benefit from addressing. Similarly, when the space, atmosphere, and design an explicit alcohol-related message of drinking isn't center stage combined with other elements, it encountered ambivalence and even hostility, as our field note there illustrates in the bold. So what do we make of all this? Well, I think we can say that although the longer term effects of public art installations are unclear, they may be useful, interesting ways of engaging young adults in culture change projects as they encounter and move through nighttime entertainment precincts. They are, of course, not a panacea, and they are by definition temporary, but may be helpful, I think, as part of a bundle of other culture change and public health efforts. I think playful and fun design elements seem to afford diverse opportunities for interacting with public art, and I suggest that maybe the same is likely to be the case for any culture change or public health project for that matter. I think there's a seriousness in public health efforts, which I understand. Public health deals with serious issues, but I don't think that necessarily needs to be at the expense of fun in all cases. I think the subtle and positively framed messaging that engages with people's complex lived experiences of alcohol use and going out might be more desirable than more explicit or traditional health promotion messaging that kind of tells people what to do. I think that some care needs to be taken in ensuring that messaging isn't too opaque, But I think people are able and perhaps even desire to engage with some of that complexity. So I think it would be wrong of us to kind of deny people that opportunity, or that we might be selling them short and their capacity short. It goes without saying that we need to involve young adults or whoever the target population is in the development of culture change projects. Often the groups that we're working with are already living and doing the culture change. And I think we see young adults leading the charge, the culture change charge, in a whole range of areas, including in relation to changing norms around alcohol, but also gender, race, sexuality, and so on. So I think our role is potentially to amplify and support, not to dictate where and how that change occurs. Good intention and the final point, I think, is that good intention and design is not enough. Unanticipated forms of engagement may still emerge as art installations or any project are situated in unpredictable and dynamic nighttime entertainment public spaces, which reiterates the need for research to kind of trace how culture change efforts materialize and evolve as they're implemented in the world with all its messiness and complexity. And I think we also may want to engage with and intervene in things like masculinity, which were present in the atmospheres and spaces that we observed. Speaking of which, we're continuing to explore the potential of art for culture change through our Animating Alcohol Culture Change Among Male Hospitality Workers project. But I think more on that another time. And I just quickly wanted to note that you can also find some useful practice-based insights in Vic Health's Alcohol Cultures Guide, which you can see on the screen. And I'd just like to thank everyone who participated in the project and the project team, as well as Vic Health and others. And I think I'll leave it there. So thank you to for listening. So I'll hand it over to Liz now.
Thanks, Michael. I'm assuming that wasn't last year during the pandemic with your photos.
No, it wasn't.
I really enjoyed that. We're switching a couple of gears now, but I'm really delighted to be invited to share this work that we've been doing, led in the Department of General Practice, but involving a lot of researchers across Monash, including Tina and Susie Nielsen at Mark. We've been lucky enough to be looking at how can general practice be involved in reducing alcohol-related harm. So I'm here talking on behalf of a big team, and this is a project that's sort of about 2/3 of the way through, and I'd like to share some early findings and things that kind of surprised us in the work that we've been doing. Again, this is work that's been funded by Vic Health as well through an impact grant. So what I'd like to just briefly go over is looking at the role of general practice in reducing harm related to alcohol, some of the qualitative data and a model that we've come up with to understand what we've found a little better, and then have a look at what we've been doing in the REACH project and the implementation trial that's being undertaken right now. So GPs, this is from the RACGP, so the Royal Australian College for General Practice. They do a Health of the Nation report each year, and they survey GPs to see what's happening on the ground. And it always surprises me that there are over 8,000 general practices in Australia, and a number of GPs, obviously, that work in each one. There's around about 40,000 GPs across Australia, and just over 1/3 of our workforce is over the age of 55. So the average GP, if there can be such a thing, they see about 102 patients each week, and on average spend 16 minutes with each patient, which is often a little more than people think when we think about the media cycle on quick appointments and quick GP appointments. It's good to highlight too that to be a GP, you do have to do specialty training. So it's at least another 3 years after you complete medical school. But for a lot of GPs, we do different things to supplement that training. And for me, I did about 8 years of extra training before becoming a GP. I'll move on now to what general practice actually is. So as a specialty, what we're trying to achieve is person-centered care, which means looking at not the disease, but the person who has the disease, and care that really takes into account the context the person lives in, their family, their community, and everything else that's going on for them. So that's the kind of centering that we learn as a doctor in general practice, and that's what we're trying to achieve. So if we have a look at general practice and alcohol in specifically, we have this thing called the Red Book in general practice, and it takes us through guidelines for all prevention practices. So you're looking at cervical screening and breast screening, blood pressure testing, but also around alcohol, smoking, nutrition and activity, physical activity. And what it says is that general practice should be involved in talking to people about their alcohol use. And we have different ways of screening people and asking them about how much alcohol they're drinking. And the idea is that if we can then do a brief intervention, which is discussing with a person around the risk and harms and what could be done, we can effectively reduce people's amount they drink each week. And we know that from effectiveness trials that have been done. We also know that if GPs do that, we will pick up people who are drinking at more harmful levels and perhaps have alcohol dependency, and they require more wraparound support, and we then liaise and refer with our tertiary centre colleagues. So although this is the recommendation for GPs, we do know that not every person is being talked to about alcohol with their GP. And often the finger gets pointed at GPs and it says, you know, why aren't you guys doing this stuff? This is your role. It's in your Red Book. You should be doing it. So our project is really about unpacking and exploring about why aren't those conversations happening perhaps as much as our guidelines, which suggest they should, and that we know we can be effective as GPs if we have those conversations. So what we went out and did is we spoke to GPs, we spoke to practice nurses, and we spoke to patients as well. And all this data was collected pre-pandemic. I feel like we need like a little PPC or something in our data now. But we did go out to practices and talk to them as a practice team. And if people preferred, we spoke to them one-on-one in an interview. And this was what we found out. So generally, when we're talking about, why GPs are not talking about alcohol, but it's actually pretty common if you think about any clinical encounter with GPs or physios or social workers, whoever you're looking at, we often drill down on the practitioner and go, why aren't they doing what we think they should be doing or what the guidelines would recommend? And that's really where we kind of focus our gaze and wonder what's going on there. But our data suggested that actually, what was happening between that doctor and the patient within the consultation was actually more like a kind of layered onion with lots of different factors right out from the community, right through down to that patient walking into the practice and into that consultation room. So these are two quotes thinking about the GP themselves. So we'll start at where we would normally start with the GP. So we did find that some GPs were talking about, well, I'm a little confused. I hear these messages about alcohol being a little bit good for you. I've heard those in the media. And I wonder about actually whether there's some benefit for my patients if they do drink a bit of alcohol. And although that is surprising, we have to remember that GPs are humans. And sometimes we forget that they're humans living in the community and they're absorbing those messages that come via alcohol industry messaging, different research projects that might be talked about in the media, and they absorb all of that information just like a regular member of the community. Absolutely, they have medical training and they should be thinking more deeply and critically about these issues. But when we do know marketing is extremely effective, that's why we have the kind of advertising we do. And with that, perhaps we know filters into GPs as well. The other thing that was discussed, that the GP's own drinking behaviour. So we have colleagues that don't drink for cultural reasons, religious reasons. Perhaps they might have more difficulty with these conversations, but also on the other end, GPs that drink more heavily, they might have difficulties with these conversations too. So it's a little bit more complex than just thinking, oh, we need to tell the GPs what to say and they will say it. So moving on now to the next bit of our model is thinking about the patient themselves. And there was a clear theme through both the patients and the clinicians and the practices about shame. So shame is a really powerful emotion, and it can stop people talking openly and honestly with their doctor. So shame around how much people are drinking can affect that conversation. There was also strong, we heard some of that through Michael's quotes as well, where people don't want to be told what to do. I mean, we're all human. I don't know about you, but if someone tells me I can't do something, it kind of makes me want to do it a bit more sometimes. And so we saw that really reflected in our data, that the way that conversation is had is really important. And that this was an interesting idea we hadn't reflected on and hadn't thought about, but sometimes maybe if alcohol is brought up in the history taking alongside illicit drugs, that might add to people's shame and make them not want to talk about their alcohol use. So again, the context of the conversation, why it's been had, is really important. So in our model, we're thinking now about the patient and internalized stigma, as well as coming from the community and knowledge about alcohol harms, which we'll come back to. And then within the consultation itself, I mean, pretty much with any general practice research, you can put time as a factor as one of the barriers. Time is an interesting one. So if we think about time in packets of a consultation, it is very limited. We saw at the beginning on average 16 minutes, but shorter or longer at different times. But as a GP, I like to think about time across a continuum. I know if I look after someone over 10 years, I'm going to see them on multiple occasions. So time has a bit of a different element than just that one-off consultation. We'll now think about the practice itself. So whether the practice that you work in has kind of a practice culture of prevention was seen as important. So if the senior GPs in the practice were really open to talking about alcohol, prevention was on everyone's radar, it felt more natural to have these conversations with the patient, and they were often set up better because there were structures in place for patients to be asked about their health behaviours before they even entered your consultation room, say through a practice waiting room survey or a nurse seeing a patient for their observations and some of the history. The other big issue that came out was a real reflection on our health system. So even though we pride ourselves on universal health care in Australia, we definitely see sort of a two-tiered access when it comes to AOD. And GPs saying strongly that sometimes when you have these conversations and you do hear about alcohol dependency, depending on whether a patient has private health insurance, depends on the kind of access they're going to have to other care. And that can be a real, definitely an issue for patients. But some GPs say, look, I'm hesitant to open up that can of worms because I don't have anywhere to send someone to get them the help they'll need. And I just feel a bit helpless then if I've had that conversation, but nothing to do with it. So that's about the practice itself and the culture of the practice. And then about the referral system and options available. And the final part of our model that we've been exploring is around community levels of knowledge about alcohol and its potential harms. And the big thing that the GPs brought up was around smoking. And they said, you know, I've never had a patient come in my room and when I talk about the harms of smoking, that it's been a surprise to them at all. It seems a fairly ingrained kind of thing in our community that, yes, people smoke, but people are pretty aware of the harms around it. But they compared those to the conversations around alcohol, where very often you're starting at a very basic understanding around alcohol harms, and that patients were really surprised when there were harms from even small amounts of alcohol use. And they said that, look, you don't ever see it out in public, campaigns around alcohol harms. It's a really uncommon public health message. And so they felt, often GPs felt, look, if I had that kind of priming of the patient is already has some of that background knowledge, and I can then build on that in the consultation, that would make life a lot easier. But I'm starting from a really different place than compared to smoking. Again, the stigma around alcohol use, and then even the differential advice. So a patient may have seen another GP and been told, oh, that's all right, it's not too much, wherein it doesn't reflect current practice. So this is the model we've been working with in the REACH project, and thinking about the layers of all of those factors that really influence what happens in that conversation between the GP and the patient. So what's said between the GP and the patient isn't just what happens in that room. It's been shaped right out from the community and the patient understanding to the practice, to what is happening in the consultation, and then the GP and patient themselves. It's actually a really useful way of thinking about practice change and how we could support GPs. So we've realised in our team that, you know, there's not going to be a magic bullet. It's not going to be that we can give GPs a little training program and it's all going to be fixed. That we often do see didactic education aimed at GPs and other health professionals as kind of a quick fix. And, you know, as educators, we know that is kind of an easy way to get your message across, but we know there's very little practice change that happens from didactic education. And so as a team, we're thinking, right, there are parts of this system we can influence in our project. Which bits can we tackle, and which bits can we highlight to other people in webinars like this, that we all need to work together to look at the different layers of the system. So we have made some practice resources, and these are to put up in the general practice, display on websites, to use within the consultation. The other thing I didn't mention was that sometimes GPs even said patients didn't think they were a good place to talk about alcohol. So priming the patient through the website, through the waiting room, this is a place that you can talk about alcohol, and your GP is someone that is trained and expects to talk to you about alcohol. We've made patient-facing brochures. We worked with Enliven, who's one of the primary care partnerships in the Southeast. They make fantastic patient-facing resources, including translations. And then, of course, we had all of this set up to go, and COVID hit. So our project really reshaped and adapted very rapidly, and we were able to now incorporate telehealth into how we got the GP and the patient to interact around alcohol through a platform called GoShare. So GPs can text or email patients information, and also share educational information. So we are in the middle of our implementation trial. For those who are interested in theory, we've been using normalization process theory to think about how clinicians embed these new practices in their daily routine. If you haven't heard of that theory, I really recommend having a look. It's about how people normalize a new behavior to become their new normal, as in normalization. We've also looked at priming the patient, because that was a strong message from the GPs about the patients not having much knowledge or awareness at the start of the conversation. We've also really worked strongly with our primary health network partner at Northwestern Melbourne PHN. So there's a practice champion and the PHN relationship manager that interact. So we're trying to be as hands-off as we can as researchers to make sure it's something we could scale up. And they talk about the alcohol that's been recorded within the practice notes and give the practice feedback. So I've got a feedback loop going on there as well. So we should have really good data by the end of the year. It will be very unique in that it will incorporate what happens during a pandemic, which I hope we'll never have an occasion to research again in our lives. But yeah, we're looking forward to seeing what's happening, and I hope that's been helpful and made you think a little bit differently about consultations and what happens in general practice. Thank you, Tina. I'll hand over to you now.
Thanks very much for that, Liz. That was brilliant. I enjoyed all the little anecdotes. Those are my favorite bits. So my part in this is to briefly recap what has been discussed by Michael and Liz I'll give a couple of examples of some of the ways in which we can see culture change having occurred in the past 20 years or so, and then start opening up for participant Q&A. So if you can throw some of your questions down in the chat box, I will be able to have a squiz at them soon enough. So Michael opened up for us, giving us a lot of fantastic, rich theoretical background, talking about what culture change is. So, for example, including those social rules and expectations we have around alcohol, which then in turn influence what is socially acceptable or not, and therefore the types of behaviors we're most likely to get. He contrasted how, culture change as viewed by public health is traditionally individually focused, but we're getting a lot more sophisticated these days, and considering that brilliant onion diagram that Liz presented with all the different layers of influence and how they all interact and they're all important, we need to address them all to sort of get that forward movement. Michael also described how, his respondents were more or less receptive to certain messages, and that some of the messages which, the people seemed to respond to best were those which were subtle, positively framed, and acknowledged the complexity of our feelings around alcohol. Really understand that, people drink for a range of reasons, and, health is but one of those considerations. So there's a sophistication required in that conversation. And that was really, really demonstrated beautifully by Liz I think you said it very simply, it's not just the message, but it's the way in which we deliver that message. So, GP clinics are not necessarily seen as a great place to talk about alcohol sometimes, because people might bring their own baggage around, whether or not it's going to open up a moral can of worms that they don't necessarily have the time or capacity to address. But, again, some of the fantastic strategies which GPs identified as helping that conversation come along. So Liz talked about priming the patient, for example, the doctors feeling really supported, that they were able to talk about alcohol-related issues if the patient came in with some understanding of some of the health harms already, and having great support within the clinic. So thinking about the clinic as sort of like a little mini society which can really facilitate those conversations for both the GPs and the flow-on benefits for the patients. So to wrap up that fantastic onion diagram, I'm obsessed with it. For implementation science and for great implementation, we need to have the whole system on board to really address this. And so this is why we've got all these different speakers today. We're all chipping away at different aspects of that onion. Liz is in the GP, really looking at, the medical practitioners who can have these conversations. Michael was giving some great examples of how, the members of the public could have these things in the back of their mind, maybe ready for them to come into a GP clinic and be asked about these questions. So I'm going to ask our fantastic facilitator, Kelly, to help me share some slides right now. So I'm going to give 3 examples. If I have enough time, please let me know if I go on for too long. The first example is really around, what is some evidence that, some of these social expectations have changed over time. We do know that it is, a slower to observe, these broad cultural changes compared to, some sort of fast-paced individual level change. But I'll give an example of how we can see some of that cultural change occur through the NHMRC's lower risk drinking guidelines. So these are the official guidelines which, you could argue is the Australian government's most comprehensive documentation of, what our drinking culture is like, or what some of the health benefits or not so much are around. It's kind of our most official drinking document. So I'm harking back here to our 2001 guidelines. Here, 20 years ago, we can see that I showed this to a couple of colleagues today, and they're sort of said, oh, that's that's interesting, that the 2001 guidelines for young people up to 18 years old, so children and adolescents, if the child or adolescent chooses not to drink, they should be supported in this decision. And the guidelines say to become a responsible adult drinker, a gradual supervised introduction to alcohol is recommended. So 20 years ago, our official guidelines, considered underage drinking to be, or drinking amongst young people to be, more or less inevitable, and considered it to be quite an unusual behavior if they chose not to drink, as specified in guideline 10.2. And Kelly, if we can skip to the next slide, which is another 10 years from that slide, we start to see the guidelines consider more scientific evidence in their descriptions of the guidelines, and they're a little bit more cautious now in the 2009 guidelines. They say maybe not drinking alcohol is the safest option. And we can skip now to the most recent 2020 guidelines, which are much clearer compared to the 2009 guidelines. They say very explicitly, children and people under 18 years of age should not drink alcohol. And the documents are very, very different in that they sort of shift toward a scientific consensus. They talk much more about the scientific background, which involves young people aged 19 and under. So, therefore, we should probably consider that instead of just leaving it up for household level negotiation around underage drinking. So if I can skip to that last slide, Kelly, that sort of just summarizes the changes in language in those official documents, going from the, what you could consider the inevitability of underage drinking, yet, you should probably just gradually introduce this alcohol to the child, all the way to 2020, where they're really providing quite a clear-cut point at which alcohol use is appropriate. And this is definitely not occurring in isolation. So this is occurring at the same time our general public attitudes are changing as well. So we can probably finish with those slides. My other examples don't actually have any slides. So we're seeing this at the same time as our secondary supply laws change in Australia as well. So in every jurisdiction now in Australia, we have secondary supply laws which say that you as a parent can provide your child with alcohol within your private premise, but someone else cannot. So if you have, say, a 16-year-old child and they bring a friend home and you're having dinner together, you're having spaghetti bolognese, maybe that pairs well with red wine. These secondary supply laws say that it's appropriate to provide your own child for, that glass of red wine if you see it as being appropriate, but it's certainly not appropriate to provide for your child's friend. That's sort of the social expectation has been put into law now, that it is a household level decision now. And these laws have come in over the past 100 years. The earliest one came in through in 1935 in Tasmania, and most recently in 2017 in South Australia. So they definitely didn't come in isolation. It's very reflective of all of our household attitude surveys, where they ask parents, like, how concerned about alcohol are you, and what does that mean for your parenting practices? So what I'm trying to get at is that it's all reciprocal, and in terms of the actual evidence that we see of culture change, what are we trying to get at with these guidelines? We do see that change as well. So Australian teen alcohol use has almost halved over the past 20 years. So for example, the prevalence of alcohol use in the past 30 days amongst 16 to 17-year-old students went from about 70% in 1999 to 37% in 2017 in Australia. So that's a big change in how we as a society, have, you know, under 18s drink alcohol or not drink alcohol. And I've just got an Outlook pop-up, sorry. So what I'm trying to emphasize here is that it can be sort of slow, but very observable within our lifetimes. Those were some big changes in consumption habits over the past 20 years, and there's some really big changes that we've seen in our most official documents. In terms of looping back to the onion diagram and using the analogy of biting, you know, we've got this monolith of, you know, drinking culture, which, you know, might be associated with more harms, and we're trying to have something that is associated with fewer harms. It seems like all these little nibbles around that we can see evidence of in our official documents, they all help each other, and, you know, that's how we're going to get that large scale health change. So I'm going to flip to our Q&A section, and I might start with something very, very specific for Liz. Oh, great. Liz has already answered that. She's posted a link to some of the resources, so if folks are interested in that, they can click through to that. So I might ask Liz another specific question. So Liz, it seemed GP training on screening and brief intervention was necessary, but not necessarily sufficient for widespread screening and brief intervention use. From your interviews and knowledge of the literature, what do GPs report when they felt more supported by, say, the clinic, administrators, or mass media, public health messaging to be able to deliver screening and brief interventions? In short, what were some of the ways that a GP felt like they were supported to deliver routine screening and brief intervention?
Thanks, Tina. Yeah, reflecting like on our sample, there were practices that seemed to be more embracing of talking about alcohol with their patients. And the things we could definitely see was that there were senior GPs in the practice who led and who were good knowledge sources, that the GPs knew that if they did open that can of worms, they knew where they could seek help in the health system. But even more importantly, it was help that they trusted. So when we refer our patients to other practitioners, I mean, I like to know for my own patients that I'm handing them over to someone that is a really good practitioner, it's going to take good care of them, and we're going to work as a team. So sometimes in referral systems, if we have a more centralized referral system where you kind of just send your patient's name in and they get through the system somehow, I don't know who I'm actually sending them to. That lack of trust and that break of relationship between practitioners can be problematic. And you know, the other big thing, I mean, it is time. So we have set up our general practice system in Australia to be a fee for service structure. So we get paid as GPs based on usually on time that we spend, but it's how many times we see the person. And that was really set up quite a long time ago now in the 80s, when there was more acute focus on acute health issues and not prevention. So even though sometimes when we look at our GPs and how it's set up, I think sometimes the way it's working is how we've made it to set up to work. So thinking about big system change and how that might look differently, I mean, that's always scary for GPs and practices and the community, but is the system really serving the purpose we need it to now?
Fantastic. Thank you. Thank you so much for that comprehensive response. I might throw a question to you, Michael. So it seems that culture change is incredibly, from my perspective, incredibly difficult to monitor. I can see, you know, some very high level late changes, but you know, it seems to be quite far down the chain. So yeah, it does seem to occur more slowly than individual change. It speaks to our communal expectations and understandings, as well as, you know, the more tangible, easier to monitor behaviours. Can you tell us about some of the proxies and outcomes that will help us track what culture change looks like, or even what culture looks like, and how we can sort of see when it is starting to change?
Thanks, Nina. Yeah, that's a great question. And I think, as I mentioned, I think, we both mentioned that sort of cultures, while cultures are on the move, sometimes because of their scale and how entrenched some practices are, movement can be slow. But I think for norms and practices to kind of take hold, as we've seen with smoking or drink driving or other things, I think we are looking at a long-term prospect, potentially more like years or decades rather than days or months. And I think that throws up a challenge for researchers and funders. I suppose our research is often and projects are often short-term and don't always have the resources to kind of sustain culture change or monitor culture change in the long term. But I think there are some useful sort of, I think, using sort of qualitative methods and other methods, observation, thinking about, asking people about the norms, what they think is acceptable or not acceptable, and how that might differ in different social situations and social groups. So I think norms are potentially a really good thing to kind of look at, because they're embedded within a lot of meanings and ideas about practice, how practice might change. I don't know if that answers it, but I might leave it there.
No, that's fantastic. No, you're right. Like we can absolutely capture those earlier things through qual methods, and people can sort of describe what isn't necessarily all that front of mind through that interactive process with the interview, and we can sort of really delve into that. That's fantastic. So I will. Do we have any more questions? I think we've got a pretty great session, and I think we're running out of time now. So Susie has popped up. I will hand over to her. Thanks, everyone.
Great, and thank you so much to our three speakers, Michael, Liz, and to Tina as well, for a really fantastic presentation. We are just about out of time, so I really just wanted to say a very big thank you. To let people know, we actually won't hold a webinar in April due to sort of holidays and people being away, etc. So we look forward to coming back for another interdisciplinary webinar in May. But I think these speakers have really highlighted how important it is to think across different disciplines and different parts of our community, to be able to think about how we can work together to reduce alcohol-related harm and change culture for the better. So yeah, thanks for joining us, and we'll catch you in May.